My name is Michael Battelle, and I'm the president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with NAFLD and NASH by advocating for access to approved treatments and care. The AASLD Liver Conference 2022 in Washington, D.C. was fantastic this year, with so many friends and colleagues meeting in person. One hepatologist who I know loved every minute of the conference this year is Dr. Mark Swain, hepatologist, professor of medicine at the University of Calgary in Alberta, Canada, a founding member of the Canadian NASH Network, also known as CANNASH, and the president of the Canadian Association for the Study of the Liver. Mark, what were your top takeaways that you can share with us today?
Yeah, thanks, Michael, and thanks for having me on. I agree. It was a great meeting, and it was enjoyable to go back to Washington, actually, where I lived many years ago for a number of years, and it was also wonderful to experience the weather there, which was like 25 Celsius, and I came home when it was minus 15, so that was a bit of a shocker. But that's the joys of living in Canada. So. I think the meeting this year, as you say, was very interesting. It was nice to get together again and see everyone in person. To move away from as we move away from the virtual meetings, hopefully, and start to engage, at these meetings face to face. I think there was a number of themes that sort of grabbed me at this year's meeting, and I'll share those with you. And what kind of I took away, and I mean, there's this ongoing. Struggle might not be the right word, but I guess it's a trying to figure out what are the best ways of figuring out how much scarring is in the liver in people that have fatty liver disease without doing a liver biopsy. So these non-invasive tests, or NITs. And there was a lot of stuff on those at this meeting, and I think we're moving closer to having those. Certainly, a number of these tests are pretty good at saying someone is at low risk of having scarring in the liver, but they're a little bit less effective at looking at grading people how much scarring is in the liver as they get to differentiate people with sort of a moderate amount, a little bit more, or cirrhosis. And so there's a lot of overlap in those tests, and so depending on what the driver is for ultimately for the therapies that come along onto the market that we can use to write prescriptions to treat people with NASH and NAFLD. I think they'll need to be a bit better than they are now to be able to do that without a liver biopsy. So that'll be interesting to see how those develop. But obviously, it's an area of significant ongoing effort and energy, and so I'm pretty optimistic that they'll figure it out at some point. Another thing that's becoming quite clear, and I think it makes sense, is that when you use like one of the most broadly used tests is something called a FIB4, and that test is actually parts of that test are being used in many of these newer sort of blood test marker things that are being developed to look for liver scarring. And there's one called Agile 3, one called Agile 4, but they're really just sort of super FIB4 tests. They just add more stuff in, and these tests all have age in them as a one of the important factors of making a number, and the higher that number, the more likely the chances that you have significant scarring. So the problem is, of course, is that younger people are going to be are less likely to have a score that would be considered significant, even though we're recognizing significant scarring in more and more people that are younger and younger and younger. And so we have to figure out a way around that, where we do use different cutoffs for these tests for different ages. And so these are things that are in fluid kind of investigation. I expect that by the next AASLD they'll be a little bit better, and every year they'll get better and better. Another sort of theme that came up was the socioeconomic drivers of NASH and sort of worse or poorer outcomes with people that have fatty liver disease and NASH. So we've known for a long time that there are significant socioeconomic drivers. So a classic example is when people would say, well, the best diet for fatty liver disease is a Mediterranean diet. But then but Mediterranean diets are expensive. It's fresh fish, fresh um, fresh chicken, and these kinds of things. So when you're doing uh, when you're recommending to someone about having a doing a Mediterranean diet, it's very hard if they don't have the financial means to be able to afford that diet. And so and often people, if they if they're working two jobs, they don't really have time to do anything except really work and provide for themselves and their family. It's very hard for them to buy very expensive foods that would be part of a Mediterranean diet, fresh vegetables, all the stuff that goes along with that. And so it makes total sense that people that who can't afford to do that, either through time or through finances, are going to be at a risk of eating foods that they can afford, which are often very carbohydrate laden, and really are foods that are going to drive worse NASH and worse liver outcomes. So I think we need to spend more time thinking about that, and how we can make sure that how we approach NASH and NAFLD is for everybody. It's not just for the people that can afford the treatments that come along. And so these are very important discussions to have, and that we have to have them more. And I think it was front and center at AASLD this year. There was along the carbohydrate diet line, there was a very interesting study that came from Denmark, where they looked at they essentially compared a keto type diet, so high fat, low carbohydrate, and compared it to a low fat diet. And all the participants took the same amount of calories in, so it wasn't a calorie issue. It was really just about one diet focused more on cutting back carbohydrates, and it was quite clear that carbohydrates are the critical driver of NASH and NAFLD and poor outcomes. Well, not so much poor outcomes; it wasn't long enough, but more aggressive disease, put it that way. So very likely translating into poor outcomes. And so uh, certainly in my NASH clinic, I spent a lot of time talking about carbohydrates and cutting back carbohydrate intake, cutting back fructose intake, and the fructose containing beverages like pops and things like that. But this was a very elegantly done, very well done study, and I think it strongly reinforces that carbohydrates are something that we really need to be addressing. And there are things that we all like to eat them. There are typically our snack foods. There are our go-to foods when we're stressed out. They're easy to prepare often. And because they're so easy in our busy lives, we have a tendency to eat them more. And so we just need to really focus energy on trying to at least address it with individuals who have NAFLD and NASH, but also work on ways that we can provide alternatives that are as easily accessible, but less I guess hepatotoxic or liver damaging.
It's Mark, it's interesting just about, so Camilla Dalby Hansen was the person who presented at AASLD, and we had a discussion with her also at the Fatty Liver Alliance. And what she pointed out too, which is interesting, is it didn't matter what fat they ate.
That's right.
They told people to eat healthy, but they were able to eat whatever they wanted to, and not all of it was healthy. And actually, the type of fat that they ingested did not make a difference, which is really interesting.
Yeah. I mean, if you look at people on a keto diet, they're often having whipped cream and bacon and stuff that you wouldn't normally pick out to be, healthy choices. But it tells us a lot. We're learning a lot about how the dietary drivers of fatty liver, and often we focus on, well, we need a pill or we need this to help us get through. But we have to look at a holistic approach, which involves the socioeconomic drivers, which are also often tied into carbohydrate intake. Because it's so easy to access and cheap, and then really try to frame therapy in a holistic kind of way, so that individuals, so the health of the individual is taken into account. And diet, we know, is a huge driver of it, because as countries become more and more developed with regards to their economies, the diets shift from a more traditional type of diets, which their bodies have become used to through generations and generations of eating that way, to shifting into more of a Western diet, which is sort of more fast food, high carbohydrate, high fructose. And NAFLD takes off right after that and follows it directly. So it's an issue that we can't lose sight of as we develop new therapeutics going forward. The other thing that I think makes sense, but it was a number of sort of studies were looking at it, was the use of things like FibroScan, which is an assessment of liver stiffness with using sound waves or ultrasound type methodologies, and that we all see individuals over time that get better or get worse with those FibroScan results, and there are more studies coming out that suggest that if that over time, if the FibroScan is worsening, so the liver is becoming stiffer, then that bodes less well for that person with regards to liver outcomes and developing severe scarring, cirrhosis, and then developing the complications related to that. So I think it's really important that we use these type of tests like FibroScans, shear wave elastography, the NITs I was talking about at the beginning, to try to really get a more dynamic impression of what's happening with people's livers over time. And it's not just a snapshot once in time; it's actually looking at them every 2 to 3 years or whatever to see how things are going. If they're getting worse, they suggest that things are worse. Then it's something we really have to pay attention to.
I also did read an abstract that talked about the liver stiffness that's being measured with those scans that may actually be attributed to damage caused by cardiovascular. And so they should get scanned for or checked for atrial fibrillation also, right?
Yeah,
You
yeah.
saw, yeah.
Yeah, there's this growing, I guess, appreciation that that NASH itself and more advanced scarring in the liver is a risk factor for other things that are not liver related. So there's been a lot of attention paid to cardiovascular risk, and so there's a number of studies. There's a very nice recent meta-analysis last year in Lancet GI and Hepatology where they showed that NASH is well, advanced liver fibrosis really is a independent risk factor for heart disease and coronary artery disease and poor cardiovascular outcomes. So I think that's interesting. And then at the meeting this year, there was a study, an abstract that goes along with it, also a growing body of evidence that the same thing holds true for people that, with regards to kidney disease. And so individuals with more significant liver fibrosis and NASH are more likely to have issues with chronic kidney disease, and that the NASH itself is an independent risk factor for that.
Okay.
So,
Oh, no, I was going to say, great.
no,
I
yeah.
love all the things you've been sharing so far. Do you have more that you want to share too?
No, that's I think that's good. That's kind of the things that kind of grab me.
Great. I wanted to add too, and I didn't want to interrupt you when you were speaking before about the non-invasive testing, that really the message that I got, Stephen Harrison talked about it a few times in different talks, that really, as you said, FIB4 is really the starting point because of the cost and low cost and accessibility, but that it will very likely be a combination of evaluations that are done, and that may be biomarkers also, as you said as well, the two things together.
And I think the utility of many of these tests is that, I mean, the appreciation of NASH and NAFLD is that even though I'm speaking as a specialist, this is a disorder or a condition that needs to be diagnosed and evaluated in primary care. There's not enough liver specialists in the world to see 25% of the adult population in the world that has NASH and NAFLD. And so there needs to be a way of screening large groups of people to say, hey, this person has a liver issue, and this person, we should worry more about their heart and the other risk factors, the other organ systems that are involved by metabolic dysfunction, which is really the driver of fatty liver disease. And so FIB4 is a good tool to use in primary care. So with a family doctor who can screen someone using FIB4, and if it's low, and the cutoff, can be determined, but there are a number of ones that have been suggested, then those people are at very low risk. And then keep doing it sequentially every 2 to 3 years to say, well, these people are at very low risk of significant scarring, which is the main issue that we're worried about in for poor liver outcomes. And so they don't need to see a liver specialist. It's the people that have more liver scarring or appear to be more at risk for that, so they have a higher score, that should be referred on. And so when we start to get better at identifying those patients in primary care, we'll make better use of our resources, that when it comes to liver specialists, or people can assess these individuals for liver disease. And
Yeah.
so really, I think that's going to be the critical thing as we shift that evaluation into primary care.
And by the way, special shout out to Richard Sterling, who created FIP4, just to remind people that it all started with one guy with that.
That's
So,
right. Yeah. Like most things, right?
so we appreciate you, Richard, wherever you are. Dr. Mark Swain, thank you so much again, as always, for sharing insights. I know that not everybody could come to the meeting, so those are really, really great takeaways, and appreciate it greatly.
Thank you. My pleasure. It's always a pleasure to be on with you, Mike.
Thanks.